of you. Uh, uh, as we all know, that glaucoma is a irreversible cause of blindness, and it is the leading cause of blindness in the world. So, if we talk of India also alone, about 12 to 15% of the people in India are suffering from glaucoma. Out of this, almost 60% have primary open-angle glaucoma, and 40% have angle closure glaucoma. So glaucoma is like a thief. It steals our vision without the patient actually knowing it. So it is very important. And of course, I would like to thank my co-instructors, Mrs. Mariam Madam and Dr. Gunjan. Um, So, we will be talking on back to basics of glaucoma surgery, and I'll be covering the ologen implant and the nuances of trabeculectomy surgery. So, what is ologen implant? I've been doing it for the last 3-4 years with very good results. So, ologen implant it is a biodegradable. It biodegrades in 90 to 180 days. Porous porcine collagen matrix. It has become quite popular of late as it improves the long-term success rate of trabeculectomy by decreasing scarring. So it is very simple procedure. You have to do a good trabeculectomy, and that I'll show the video how to do a good trabeculectomy, the small nuances to do a good trabeculectomy. So the procedure is same. You have to do a conventional trabeculectomy. At the end of the surgery, the implant is placed subconjunctivally, and the best thing is you don't have to titrate it. You just have to remove it from the pouch, and you can put it below the conjunctiva. The other, you can also optimize it according to your size. Nowadays, many a times we cut a small triangular piece and place it below the sclera, and take loose sutures, especially the apex one, and take the conjunctival sutures. इसको मिनिमाइज करके वीडियो वहीं से यहाँ से रोकना है तो pause ना okay. So I'll show you trabeculectomy with ologen implant. So first important point, this is a pseudophakic eye refractory glaucoma. So I decided to go for not for only for conventional trabeculectomy but with ologen implant. So here you see, first you have to make, you can make a limbal based trabeculectomy or a fornix based trabeculectomy. I usually prefer a fornix based trabeculectomy because of my comfort. Now one thing is, 4-5 years back the concept of microfiltration was there, but I don't get good results with microfiltration, and so I make a good 180-degree conjunctival flap and dissect it quite posteriorly, so that you can get enough subconjunctival space to for the aqueous to drain, and you don't have to cauterize much. More you cauterize, more the fibrosis will be there. I prefer a triangular flap. You can make a rectangular flap, and you have to dissect the triangular flap, and you have to see this is the Schwall base line, and you have to go anterior to the Schwall base line, because we want to make the window anterior to the Schwall base line, And this is the problem where many doctors, they make the window posterior to the Schwalbe's line, and that is the reason for the failure. Do a good amount of iodectomy so that you can see even with the naked eye, and take the sutures. You have to take very loose sutures actually. Some surgeons, they prefer to take only the apex sutures. I take 3 sutures, and this is the model of the collagen implant, which is 6 millimeter in diameter and 2 millimeter in thickness. And here you have to place it subconjunctively, but you have to make it clear. This is one of my earlier videos. You have to place it above the sclera and scleral flap. And even if it displaces, you can just by the swiping movements at the end of the surgery, you can put it over the scleral flap. So now you take the routine sutures, conjunctival suturing, and the surgery is over. So you see there, you don't have to titrate it. It is very simple to use, and there is absolutely no learning curve in this, and you get very good results. You can compare it with wound modulators like mitomycin. Yeah, 1 minute. Yeah. Again, the PPT. So what is the mechanism of Ologen implant? So Ologen implant, it acts as a scaffold for the growth of fibroblast in the pores of implant, decreasing the scar formation. It acts as a physiological reservoir. It mechanically separates the conjunctiva and episcleral surface and prevents adhesions between them. So what are the advantages over MMC? Usually I use MMC a lot. But Ologen has some certain advantages over MMC. You have less bleb related complications. There are no avascular thin blebs, the typical thin mitomycin blebs, that we've seen with the mitomycin. The implant actually presses on the scleral flap. So there is, on the first and the second day, as we see with mitomycin, there is no immediate hypotony, and we don't get to see that hypotony, maculopathy, and choroidal effusion, which we often see with mitomycin. There are less chances of blebitis and endophthalmitis, and results are comparable with mitomycin. Other advantages, as I already said, that it is very easy to use. There is no learning curve actually. It is available in a sterile double pouch, and you just have to open the pouch, take out the product, and it is ready to use. It requires no prior preparation or titration. It can be trimmed, as I said earlier, according to your convenience, to adjust to different indications or surgical need, and there is no learning curve. Contraindication is only that it is very costly. It costs around 7,000, and in patients with known hypersensitivity to porcine collagen, because it's a porcine collagen matrix. So we did a study on 14 cases, a small case study. And we followed up the cases for 1 year. After 2 months, we compared with conventional trabeculectomy done alone or with Ologen implant, and there was no significant difference in the intraocular pressure. But after 6 months and 12 months, the Ologen implant patients, they fared much better than conventional trabeculectomy done alone. As compared to with the mitomycin C, after 2 months, the patients with mitomycin, the decrease in intraocular pressure was more than we saw with Ologen. But after 6 and 12 months, long-term results, they were almost same. So our criteria of success was, the primary outcome measure was, if we called it cumulative success, if the intraocular pressure was more than 5 and less than 21 millimeter of mercury without any anti-glaucoma medication. Relative success if the intraocular pressure was more than 5 and less than 21 millimeter with or without any anti-glaucoma medication. So in our small study, our relative success was 100% and cumulative success was 90%. So I would like to conclude by saying that Ologen is a very effective thing in controlling the intraocular pressure in primary open angle glaucoma, and the results are comparable to mitomycin with less side effects. Cost factor is the only limiting factor. Thank you very much. Now I would request Dr. Mariam Madam to take over the mic. And she will be speaking on complications with
Good morning, everyone. I am thankful to Scientific Committee Chairman Dr. Lalit Verma sir and Samir for giving me this opportunity. I'm going to speak about the complications of glaucoma surgery and how to manage it. This is the trabeculectomy surgery. If we do the careful assessment of a patient of the intraocular surgery, intraocular glaucoma surgeries, then there is a less chances of the complications and there are so to manage. But complications are अभी तो मैंने छुआ भी नहीं मैंने छुआ The complications are bound to occur even in the competent surgeon, in the hands of competent surgeon, but the main important thing is how you tackle these complications. So we have divided these complications of trabeculectomy into the intraoperative and the postoperative. We are not going into detail because the time is less, so the anesthetic complications and that. So intraoperative and the postoperative. In postoperative, again we divided into early postoperative and the late postoperative complications. The most common complication intraoperatively are the conjunctival buttonhole, improper scleral flap, Descemet stripping, hyphema, suprachoroidal hemorrhage, iridodialysis, cyclodialysis, lens injury. In the postoperative, early postoperative complications are the shallow anterior chamber with low or normal IOP. In this includes the wound leak, overfiltration, the choroidal effusion, and deep AC with low IOP, there may be overfiltration. Post-operative complication in the early post-operative period, the shallow anterior chamber with the high or normal IOP are the pupillary block, aqueous misdirection, and the suprachoroidal hemorrhage. While with the deep AC with high IOP, there is a failing bleb. There may be either internal block or the tenon sets formation. In the late postoperative complication includes bleb leak, large overhanging bleb, blebitis, endophthalmitis, hypotonic maculopathy, and the cataract. So now how to manage this complication? First is the conjunctival buttonhole. Usually you avoid the tooth forceps, cutting needles. The careful dissection of this conjunctiva is required. Even while taking the superior rectus suture, you can tear the conjunctiva. So in that case, you can take the corneal suture, but in the corneal suture, you must keep in mind that it must not be too thin or it is not too deep. If it is very superficial, there may be a cheese wiring of the cornea, and if it is a deep, it may cause the perforation and there is a soft eye. So in here, the careful dissection is required. Corneal traction suture you can take. Fornix based conjunctival flap is easy, and in that case, there are less chances of buttonholing. Early in surgery, if there is a buttonholing, then you may repair that defect and choose the another site. In near the limbus, then if there is tear is near the limbus, you do the peritomy, you cut that conjunctiva and then again you suture that conjunctiva in the corneoscleral junction. Late in surgery, then you have to take the horizontal mattress or the purse string suture with the 10-0 nylon or the 9-0 vicryl on the vascular needle. No cutting needle is not advisable. Improper scleral flap. You must avoid either very thin or the very thick flap. If the thin flap, there may be a chances of the disinsertion of this scleral flap, and then if there is a disinsertion, then you have to suture with the 10-0 nylon and try different side depending upon the whenever this occurs. If in the early phase, you can change the side, but if in the late phase, then you have to suture that flap. If there is a flap hole, then you have to suture if possible, sometimes with the Tenon's capsule flap, or sometimes you have to use the scleral patch graft. Descemet stripping, if there is small, no need to repair. If it is large, then we have to replace by injecting air or viscomat repair with the 10-0 nylon. If there is a hyphema, then you must, there are predisposing factors for this hyphema at the hypertension or the drug induced. If patient is on the aspirin, then there may be chances of hyphema and the clotting disorders. Bleeding from iris or ciliary processes, then you have to use this cellulose pressure, maybe with the, if patient is not hypertensive, you can use epinephrine. Irrigation with the balanced salt solution, inject air or viscoelastic. And if there is you are able to identify the point, bleeding point, then you can use the Wakefield cautery. If suprachoroidal hemorrhage, in this, there's the preoperative, if there is a patient is having preoperative high intraocular pressure, hypertension or atherosclerosis, and there is a sudden decompression of the anterior chamber, there are chances of suprachoroidal hemorrhage. The signs are flattening of the anterior chamber, sudden increase the firmness of the eye, there is a loss of red reflex and the forward movement of the intraocular content. The treatment is immediate closure, and sometimes you have to do the posterior sclerotomy to remove the blood. The lens injury, most commonly while removal of the block or during the peripheral iridectomy. So you have to use the Kelly sponge or constrict the pupil before PI, and there will be, whenever you do the paracentesis, you do the oblique, don't go horizontally. Conjunctival wound leak, there is a low IOP, shallow anterior chamber and the flat bleb. So in this you perform the Seidel test. If it is positive, either you give the pressure patch, reduce the frequency of the steroid, or you stop for 1 or 2 days. The large soft contact lens, you can be used fibrin glue if very small, there is a leak, resuturing with the, if it is large, then resuturing with the 10-0 nylon or the 8 or 9-0 Vicryl sutures. Before we manage this shallow anterior chamber, we must know how we'll grade this shallow anterior chamber, grade 1, grade 2 and grade 3. In grade 1, there is only peripheral iris corneal apposition. In grade 2, up to the pupillary border, you can see it is up to the pupillary border. And in grade 3, the lens is also touching the cornea. So in this case, there is a emergency intraocular manipulation is required in grade 3 anterior shallow anterior chamber. In the overfiltration, you can prevent overfiltration by the tight scleral closure and also by using the releasable sutures. Initially, you do the conservative line of treatment, avoid the strenuous activity and pressure patch, give the pressure patch and reduce the steroids. You can use the large contact lens on the AC. If flattened, then you inject the air or the viscoelastic or the any SF6 or C3F8. It will deepen the AC and increase the IOP, prevent cataract formation and irreversible endothelial damage. Choroidal detachment, usually conservative management, you can use cycloplegic mydriatics and the oral steroids. Surgical drainage of the effusion, you can do whenever there is a kissing choroids, corneoscleral, corneolenticular contact, or there is a patient develop corneal edema. Pupillary block, laser, surgical iridectomy or the platy iris syndrome, then iridoplasty. Suprachoroidal hemorrhage, already we have discussed in the intraoperatively. Malignant glaucoma risk factors are the eyes with the acute angle closure glaucoma, shallow AC. If shallow to flat, central and peripheral AC, and the relatively high IOP is there. So in this case, you do the BE scan, and there is a topical steroids, cycloplegic, and the IOP lowering agent is given. If with the maximum treatment is given, you can do the disruption of the anterior hyaloid phase with the Nd:YAG laser. If there is a pseudophakia, do the posterior capsulotomy. Even then it is not come under control tension, you can do the pars plana vitrectomy. This is the ideal post-operative blade. Elevated IOP deep AC, there may be inadequate filtration or there is a heavily vascularized bleb. A tenon seat that is highly elevated, smooth dome, no microcyst, large vessels but intervening avascular spaces are present. Do pattern sclerostomy, and this occurs within the first 2 months. So initially you can do the conservative management. The tenons is there may be either internal block or the external block. Internal block with the iris, ciliary body, vitreous, blood clot or fibrin, and by gonioscopic evaluation you can see what is the reason. You can do the laser suturolysis or the needling in this patient, type of patients. Digital massage is also useful. Needling you can do in this cases of tenant cyst. Blebitis. In blebitis, there is a patient may having a severe pain, hypopyon, or severe pain. If there is a hypopyon or the marked loss of vision, you must suspect in this type of patient at the endophthalmitis. The risk factors are the inferiorly located blood, mitomycin C, patient is using the mitomycin C, blebitis or blepharitis, and the contact lens, patient is using the contact lens, and the immunocompromised person. Start the empirical treatment up to the culture reports come. Endophthalmitis, you can give the intravitreal injection and treat accordingly. Prevention of the early bleb leakage by the meticulous surgical technique, careful conjunctival dissection. Avoid tooth forceps, search for the button holes, and careful use of mitomycin C. Late bleb, more common in thin cystic and ischemic bleb and depend on the individual clinical situation. Conjunctival flap advancement with the bleb preservation you can do, or the free or rotational conjunctival graft. Sometimes you will require the scleral graft, and sometimes embryonic membrane transplantation. Late bleb leakage, you always instruct the patient that if there is a red eye or the sensitivity to light or the visual acuity change or there is a pain, immediately consult the doctor. Hypotonic maculopathy, chronic hypotony, IOP is less than 6 millimeter of mercury, 2 different occasions at least 1 month apart. And then in case the risk factors are the young male person, high myopic, and the patient we use the antimetabolite in the high concentration. So these are the complications of destructive surgery you can prevent. Take home message, that is the careful assessment of the patient, identify the appropriate cause, more conservative measures to start with, surgical intervention when conservative measures fails or there is a surgical urgency. Individualize the treatment plan for each patient. Thank you for patiently hearing.
Thank you, Dr. Mariam. And now I would like to invite Dr. Kunjan Tak. She is a young dynamic glaucoma surgeon practicing in Ahmedabad, and she will be speaking on wound modulators in trabeculectomy and walls in refractory glaucoma. Dr. Kunjan, please stick to time because we have a webcast after this. Yeah?
I need a charger also. Good morning everyone. I would like to be thankful to the organizing committee for providing me this opportunity. I will be discussing about the wound modulators in trabeculectomy. Why we need wound modulators? Previously, when they were doing plain trabeculectomy without any wound modulators, these trabeculectomy usually fails after 2 to 6 months. So, to preserve the vision, we require IOP in low teens, and main determinant for long-term IOP control is a healing response. So, and the main reason also is a fibrosis and scarring, and that leads to failure of bleb. So, to control the scarring process and give patient a long-term IOP control as well as functional vision, we need a wound modulators to prevent the scarring process. There are various factors which affects the wound healing. These are the activated conjunctiva with pre-activated cells with variety of inflammatory mediators, plasma proteins, blood cells, migration of polymorphonuclear cells, macrophages, even the aqueous released from the eyes. When the bleb starts functioning and there is breakdown of blood aqueous barrier, there are release of growth factors, specifically transforming growth factor beta. It is a very fibrotic agent and that leads to bleb scarring. And in later phase, there is a collagen cross-linking and scarring also. So, in patients with neovascular glaucoma, patients with previous failed filtration surgeries, previous conjunctival incision like SICA, CCC, or patient with RD surgery or squint surgery, patients with aphakia, uveitis, chronic conjunctival inflammation, patients on long-term topical medications, patients who are having high preoperative IOP because these patients have high level of transforming growth factor beta, and patients who are elderly and young, these are very high, these patients have very high risk risk for failure due to scarring. Antimetabolites use was based on the study that the cell culture result shows that short-term applications of antimetabolites, they arrest the cellular growth for a long term. So based on that, first Parrish et al. Introduced 5-fluorouracil regimen in trabeculectomy, and it is a pyrimidine analog which interferes with RNA and ribosomal synthesis, and mitomycin C was first used by Chen, and it is a cytotoxic agent which inhibits the DNA-dependent RNA synthesis. Mitomycin is used as a single dose application, 0.1 to 0.5 mg per ml diluted with BSS, and 5-fluorouracil, it is used as a single intraoperative solution, 50 mg per ml, but it has to be augmented as a post-operative regimen also. The benefits of mitomycin C over 5-fluorouracil is mitomycin has a superior long-term IOP control, it has no corneal side effects, increased efficacy, and there is ease of application because we don't need post-operative augmentation. To optimize the effect, we have to optimize our choice of agent as well as perfect method, so that it should be under the scleral, I'll be discussing in the video. So here for applying the mitomycin C, we have to take care that the forceps which is held to use the mitomycin C should not be touching the conjunctival border which we have cut, and mitomycin C sponges ideally should be non-fragmented sponges. It should be applied very posterior so that we can have a posterior diffuse bleb, and it should be washed with thoroughly irrigating of 30 to 50 ml of BSS. So for Moorfields Eye Hospital has given us criteria what antimetabolites to use and how to use. So patients with low risk factors, no antimetabolites are required, or you can use 5-fluorouracil 50 mg per ml in 5 minutes. Intermediate risk patients where we can use 5-fluorouracil 50 mg per ml for 5 minutes, or mitomycin C 0.2 mg per ml for 3 minutes. These patients are patients on topical medication which is pilocarpine and adrenaline. Previous cataract surgery without conjunctival incision, several low risk factors, patients with combined surgery and previous conjunctival surgery. While patients who are high risk that are neovascular glaucoma, chronic persistent uveitis, what we have discussed previously, these requires mitomycin C in dose of 0.5 mg per ml for 3 minutes. 5-fluorouracil also needed as a post-operative injection. The original regimen used was of 21 injections which were given 180 degree apart from the bleb. But the study shows that at least 3 injections are required for its better effect, and if you need a proper effect, minimum number of injection required was 5. So the technique used modified was now 5-fluorouracil injections are given near the bleb with less number of injection. You can use viscoelastic to improve the long-term effect, and it should be given with a small bore needle and long track that prevents the spillage over the cornea, and that prevents the corneal side effects. Post-operative injection of mitomycin C are not used, but in needling you can use 0.01 ml of 0.4 mg per ml of mitomycin C. The drawback of these antimetabolites are because it treats relatively small treatment areas, so it can lead to thin and cystic bleb. Then there are high chances of leakage as well as hypotonia, and if hypotonia is there, hypotonic maculopathy with prolonged visual impairment can also occur. Due to thinning of a bleb, there are high chances of endophthalmitis, and if inadvertently it enters into eye, there are chances of ciliary body as well as endothelial toxicity. Ologen implant, it is a collagen matrix implant which we have discussed earlier. So it degrades within 90 to 180 days, but it gives a very controlled resistance to aqueous outflow. Other antifibroblastic therapies which are now under the studies is Tranilast, Trebio-R. Trebio-R is a human monoclonal antibody to transforming growth factor beta 2. which is a predominant form of transforming growth factor beta in aqueous and which enhances the scarring. So this acts only if the TGF beta 2 is present in the wound. Animal studies have shown improved outcome, and histologically it is less destructive to local tissue as compared to mitomycin C. Other therapy, the photodynamic therapy were previously used by some of the people. The benefit of that, it gives a very large area of exposure, so very large diffuse bleb is present with that. Matrix metalloproteinases is an enzyme which degrades the extracellular matrix. So MMP inhibitors are also in line, which reduces the scar and prevents the normal tissue. Other agents are Taxol and etoposide and cytocalcin B, which all are microtubule stabilizing agent and microfilament inhibitor. All these agents inhibits the scarring and improve the long-term outcome, but still these are under the process. Right now, what options we have is only mitomycin, 5-fluorouracil and ologen implant. But along with this, careful surgical procedure, careful handling of tissues, thoroughly not doing too much cautery, and better tissue handling, all these factors also affects the wound healing. So we'll conclude with that. Thank you.
Kunjan, you carry with the yeah.
Again, good morning. So we have discussed that despite of maximum and proper surgical care, many of the patients or many of the trabeculectomies fails, and these are the patients who are having refractory glaucoma. So refractory glaucoma is defined as uncontrolled intraocular pressure with evidence of this optic nerve and visual field defect. Despite of maximum tolerated medical treatment or systemic anti-glaucoma medications, failed treatment or combined surgical plus medication, or patients who are having high risk of failure due to trabeculectomy. The reason for failure are early failure are usually due to external occlusion by iris or vitreous, external fibrosis, and the late failure is due to external fibrosis or leaks and infections. So valves are designed to overcome two major problems. One is the silicone tube, which prevents the closure by diverting aqueous out of the eye, so that internal occlusion thing we can avoid, and external plate which prevents the scarring. These devices create an alternate aqueous pathway from anterior chamber into the subconjunctival space or suprachoroidal space by channeling the aqueous through the tube. The previously used devices were statins, which are solid shaft, which prevents wound apposition, and the stent, which is a stent is a tubular structure where fluid passes passively. But one thing is valve, which is a tubular structure with unidirectional flow, so that nothing can go into the eye. Implants are classified based on the type of plate, which may be rigid or flexible, type of material, which may be silicone, polypropylene, hydroxyapatite, as well as expandable polytetrafluoroethylene. But the main category is depending on the types of opening. The devices without resistance, so where we have to rely on the resistance formed by the fibrous capsule, which forms later on.
Dr. Gunjan, if you have some video, you can show that, because
no video
okay.
of valve.
You can make it fast because we have a webcast. It's
Fine,
in
fine.
our session only.
How much, 5
we
minutes?
didn't know that. Yeah.
Sure. Okay. Bleb grows around implant and creates a space for fluid to drain. These are Molteno implant. In original Molteno implant was a single thin acrylic plate, but then various modifications like double plate Molteno with V-shaped reach. So this V-shaped reach provides resistance which is not in a previous Molteno devices, and Molteno device with reservoir. Barweld is implant which is non-valved, which is the non-valve. It has a large surface area, but it can be inserted via one quadrant incision. Silicone tube, and it has a silicone tube, and the plate is barium impregnated to improve the visualization. It is available in 3 sizes, 250, 350 millimeter square, and pars plana also. Plate has a fenestration where the fibrous tissue grow, and which decreases the bleb height and prevents the complication due to muscle impingement and diplopia. Express valve is a stainless steel tube which is which has a barbed end which anchored into the anterior chamber. The advantage that it is easy to insert because it is directly inserted under the trabeculectomy flap. And there is no tissue cut, no bleeding, and quite eye post-operatively. Eye stent is a SS implant which is usually bypass the trabecular meshwork and drain the aqueous from anterior chamber into the Schlemm's canal. This we have to implant in the Schlemm's canal. The other devices are valve devices which drain the fluid at a certain IOP. So valve opens and fluid goes out from the eye, but whenever there is hypotony, the outside fluid cannot enter into the anterior chamber. So Ahmed glaucoma valve which opens at if the pressure is more than 12 millimeter of mercury and closes when the pressure is less than 8 millimeter of mercury. So there is a unidirectional flow. Priming is required for that. It is most commonly used device and it is available in the various sizes. Krupin implant, it is initially single implant but it is attached to 180-degree socket type of implant, but now it has a Krupin valve with disc. A valve with variable resistance are Molteno dual reach, barbelled and deep light gold medal. The advantage of valved implant, it does not require temporary occlusion, there is no early hypotony and its complications. It is a single quadrant implantation and faster surgery, but the drawback it exposes the capsular tissue to the inflammatory mediators in immediate post-operative period. It has a smaller surface area and the hypertensive phase is there. So if patients, in patients with advanced glaucoma, we don't need any hypertensive phases, there we can prefer the non-valve devices because it gives a long-term IOP control. But the disadvantage of non-valve implant that it causes early hypotony and there are many hypotony related complications. To prevent that, we have to ligate the tube of non-valve devices. Contraindication, absolute contraindication are only scleral thinning and ciliary block glaucoma. Rest are relative, which is vitreous in AC, where we can, if vitreous is plugging the tube, we can do a YAG laser. Silicon oil field eye, low visual prognosis, phakic patients. The complications include hypotony with or without choroidal effusions, which is common with non-valve devices. Tubes to prevent that, tubes can be tied off temporarily and released when the fibrous capsule forms, which provides the resistance. There may be leak around the tube. Raised IOP due to tube obstruction, if it is by iris or blood, we can manage accordingly. In hypertensive phase, we have to give topical anti-glaucoma medications. To prevent various tube-related complication, important thing is to secure the posterior plate, secure the end plate accordingly so that we can prevent anterior as well as posterior tube migration. If tube migrates or tube touches the endothelium, it can cause corneal decompensation. If tube is obstructed by iris, we can do iris or vitreous, we can do YAG laser to relieve that block. And if tube is eroded or extended, we can do conjunctival overriding, or we need sometimes in patients we need amniotic membrane grafting over that also. Rest of complications are endophthalmitis, encysted plate can migrate where we need to explant the valve. Here we have one or two patients where we have patients with congenital glaucoma, both eye trabeculectomy with mitomycin C done, both eye PK done, and then we need because this patient is having post keratoplasty, the previous surgery failed, we need to do both eye Ahmed glaucoma valve. Now IOP is under control. This is another patient where left eye lensectomy with vitrectomy and silicone oil implantation was done with inferior surgical PI. This patient is implanted with Ahmed glaucoma valve. Patient was well up to 6 to 9 months. Now we are under observation. His IOP is now controlled. Thank you.
Thank you, Dr.
For patient
Kunjan.
listening.
So now friends, fasten your seat belts, and we have a webcast with none other than Professor Jonathan Croston. Professor Jonathan is a clinical scientist and professor of ophthalmology at Duke NUS in Singapore. He has completed his ophthalmology training in Mooresfield Eye Hospital in London, PhD in UCL, and postgraduate at San Diego. He has served as head of ophthalmology in the University of Melbourne and MD at the Centre for Eye Research Australia from 2009 to 2018. His main area of interest is neuroprotection, and how to develop the optic nerve targeted treatments, enhancing neuro recovery and clinical routes for assessing and translating these to our clinics. He has published more than 180 publications, and he's the founder of Oculo platform designed to share clinical imaging referrals and clinical correspondence. And of course, not to say that he has received a number of awards for his research. So over to Dr. Neha. Neha is going to please.
Good morning, can you hear me? Good morning, are you able to hear me?
Good morning, Professor Jonathan. So we are ready here. So are you ready, sir?
I'm ready to go. Can you see my slides on the screen?
Yeah, we can see also.
Great, terrific. So it's very difficult to hear you. So I'm just going to continue. Thank you very much for inviting me to talk. I've just heard of the challenges of bringing our patients' pressures down to the low teen levels. And so I'm going to talk about neuroprotection and really move to look to the future. And this is all about developing drugs that are adjuncts to intraocular pressure lowering and in some ways take off the pressure of needing to get everyone's intraocular pressure down to 10. Now, the problem that we all face is that glaucoma being an optic neuropathy, we currently have no treatments that actually directly target retinal ganglion cells. And so new approaches are needed to bring this class of medication to the clinic. The only really substantial study that has looked at a neuroprotectant in glaucoma is the memantine study that many of you will be familiar with. This was a very well-funded study with over 2,000 patients who were treated with memantine for 2 years. But unfortunately, both of these phase 3 studies did not reach their primary endpoint. And this really put neuroprotection research back a very long way. But if you read the summary paper that came out very recently, Bob Weinreb is one of the lead authors, they came up with some interesting proposals in this discussion as to how this study could have been better designed. They also came up with 2 recommendations, and that is that we really consider alternative clinical endpoints that show change over shorter periods of time, as this would allow us to do much more cost-effective neuroprotection research. And secondly, that these short-term changes would need to obviously predict longer-term progression rates in glaucoma. So this is something that we've been addressing. Now, you're all very familiar of the relentless progression that some of our patients sadly face in glaucoma. But if you look at the panel on the right-hand side, the visual field progression, although in this case there is clear progression between 1991 and 2001, if you look at the 2-year intervals for each segment, it is sometimes quite difficult to determine whether or not that patient has in fact progressed. And this is the challenge we face in clinic, where with current endpoints, we really struggle to see progression in many patients unless it's over a very long period of time. Now, part of the problem is that most patients actually progress fairly slowly. This is data from Europe, from Anders Heil's EMGT study. And what we see is the majority of glaucoma patients are progressing at slow rates between 0 to 1 decibel per year MD. And this really creates a challenge with respect to doing any form of neuroprotection research. So the question that we posed a number of years ago is it possible to further cut the time taken down to determine if someone with glaucoma is responding to treatment or not? The paradigm that we all read in our textbooks is that in glaucoma, ganglion cells go from being healthy cells to dying. But in fact, what was probably really happening is that there's this injury state that a ganglion cell will enter into and really has the potential to recover from. And I'm going to show you some very quick data in a second to talk a little bit about visual recovery. And what we posit is whether visual recovery in response to intraocular pressure lowering or in response to a potential neuroprotectant could act as a surrogate marker that will predict a change in longer-term glaucoma outcome. And it's this neurorecovery, as we call it, that we believe holds potential in really driving forward neuroprotection research. We call these injured, non-functioning ganglion cells comatose ganglion cells, and this may be what the coma in glaucoma is all about. Is there evidence for visual recovery in the clinic? This is a very busy slide intentionally because it shows a number of studies that have all looked at different forms of visual recovery in glaucoma patients over time. The one standout here in the bottom left-hand side refers to a paper from Bob Casson in ophthalmology, where they showed an improvement in contrast sensitivity in open-angle glaucoma patients in response to increasing vitreous glucose levels using intensive drop regime for glucose. And this was particularly interesting as it may suggest that ganglion cells are bioenergetically compromised, and that if you increase energy substrates, you may improve the function of retinal ganglion cells. What about individuals, and I'm sure we've all seen in our clinics, individuals whose visual fields seem to have improved, and there's not necessarily a learning effect. Here is a set of fields from a patient that I operated on in 2008, a young tennis coach who came in with high pressures, was sporadic about taking his topical medication. I performed a trabeculectomy, and what you can see is pretty early on his visual field started to improve, and even 8 years after surgery, a substantial improvement in his visual field over time. So certainly some of our patients maintain the capacity to improve function. We've taken this into the laboratory to really study the process of neurorecovery in retinal ganglion cells, and we do this in mice by insulting their ganglion cells by raising intraocular pressure to quite high levels for a very short period of time, usually 50 millimeters of mercury for 30 minutes. And using the Espion color dome from diagnosis, we measure inner retinal function in mice. And this is the sort of readout that we see, is that mice, after a very short pressure challenge, lose ganglion cell function. This scale on the x-axis is in days. But in a young animal, by 7 days, we almost see complete recovery. But this shows us that we can measure loss of function and then recovery function in a mouse eye that's been subject to intraocular pressure elevation. Now, older animals, interestingly here in red, also show the capacity for recovery, but the recovery process is incomplete and it takes much longer. And so we're now in our laboratory studies looking at ways in which we can make older animals recover better and behave more like younger animals. And we published some papers on this, which I don't have time to cover here. This is data from Bang Bui's lab, from another lab, which uses exactly the same model. And they've charted here very nicely how you get this improvement in inner retinal function, in ganglion cell function over time after a single intraocular pressure challenge of 30 minutes. We measure a scotopic threshold response, which is largely derived from retinal ganglion cells, using standard ERG protocols. Now, we very much like the ERG because it allows a functional dissection of the retina. In mice, we use a scotopic response called the STR, and in humans, we find the photopic response, the photopic negative response, which is also derived from the inner retina, largely from retinal ganglion cells, is a robust response that we can get in most of our glaucoma patients. And I'm going to show you the data from a recent study that we've completed, which suggests that we can measure an improvement in visual function in response to a potential neuroprotective agent. We use the Espion, which is the gold standard electroretinogram, but also have more recently moved to some portable devices, which we've modified extensively to really measure the photopic negative response, the ganglion cell response in response to a flash of light. And here you see Xavier, who's a mathematician who works for me, really demonstrating the electrode and the setup that we use. It takes about 20 minutes to measure an ERG. These are light adapted patients. They don't require dark adaptation. But these studies still have to be done in a very careful manner in order to get robust data from them. One of the first studies that we did was to look at the effect of intraocular pressure lowering on the photopic negative response. I'm just going to show you this very briefly, but what we see here on the left-hand panel in the black dots is the response of a patient group who had a 30% lowering in intraocular pressure. And you see this improvement, significant improvement in intraocular pressure in a proportion of patients, not in all patients, but in a proportion of patients. And this then led us to start saying, well, could we get a similar improvement in ganglion cell function in response to a potential neuroprotective? The neuroprotective that we tried was vitamin B3, and we really chose this for two reasons. One is there was some very strong evidence from rodent studies. This was published in Science in 2017 by Pete Williams and Simon John, where they looked at an inherited mouse model of glaucoma and found that one of the earliest changes was signs of mitochondrial damage and a reduction in nicotinamide, which is the substrate for complex 1 in oxidative phosphorylation. So mitochondrial damage and evidence of bioenergetic compromise. And they proposed that if you supplemented these mice with vitamin B3, which replenished NAD levels, that you would reverse glaucoma. And this is in fact what they showed. We were interested in this study because we had previously shown that complex 1, where NAD feeds into the electron transport chain, is compromised in a significant proportion.
Professor
glaucoma patients.
Jonathan, may I interrupt you? Sir, could you please summarize in 5 minutes, because we have a next session coming up.
Okay, so I'll skip forward to the end of the study. This was a crossover design looking at nicotinamide versus placebo, and we looked at the ERG every 6 weeks as well as OCT and visual fields. And what we found, I'll skip to the data slide, and this is the key slide here, was that nicotinamide led to a significant improvement in inner retinal function that was measured in a number of different ways, both in respect to change from baseline, but also change to placebo. So what this data shows us, and I'm going to skip right to the very end, I won't show you all the data. This is now online in Medical Archive, but what we found was a significant improvement in inner retinal function in response to nicotinamide. And this is the first time that we've seen that we have, we believe, robust evidence of visual improvement in glaucoma. We now need to go on to see whether this translates into a longer-term visual improvement. And this whole concept about driving neuroprotection to work together with intraocular pressure lowering, I think is a key priority to really face the upcoming burden of glaucoma in all healthcare sectors. So thank you very much for your attention.
Thank you, sir, very much. It was a pleasure to have you with us. It was really a nice and informative new thing for us, and all the audience here are appreciating it. Thanks a lot, sir.